Good evening, everyone, and welcome back to my channel. Today, we are going to be talking about transient tachypnea of newborn. First thing to understand about transient tachypnea is the physiology of how the fetal lung gets cleared of fluid, because everybody already knows that the oxygenation of the fetal blood happens from the mom. It's not so much the baby doing anything, and actually intranatally the lungs are filled with fluid. And so what happens is 35% gets cleared few days prior to birth, 30% happens during labor, and 35% again gets cleared postnatally during crying and breathing, right? This happens like very close to in the very close to, and before, during, and around delivery of the baby, right? So the thing to know is that the fetal lung, it secretes fluid during intrauterine life and resorbs it during and after delivery, which I think is important to remember, right? So this is the physiology behind the secretion of the fluid into the fetal lung, during during gestation, chloride and fluid, they get secreted from the fetal lung epithelium, and then in late gestation, which is what I said, before, during, and after delivery, the epithelium develops the ability to resorb sodium, right? And this is due to increased expression of ENaC. This is due to increased expression of ENaC and increase in catecholamines and glucocorticoids during labor, which we know that these are the hormones that do get secreted, substances and hormones that do get secreted during labor, because it's a pretty stressful period. And then there's going to be increased oxygen tension when the child takes its first breath, right? Now, as you can see in this diagram, this is fetal lung liquid, right? This is fetal lung liquid, and this is basically this is what happens intranatally, and this is post, right? So here you can see that there's sodium and chloride. Okay, there's first chloride, right? Because we read that it's the chloride that gets secreted, and then sodium follows it, possibly because it wants to maintain electroneutrality, and then there's water coming in because sodium is osmotically active. And what happens postnatally is that ENaC expression increases and sodium goes out, so does chloride, and so does water. So that's the physiology behind resorbing the fluid after the baby is born. Now, what are the risk factors of something like this? So we already know that, just give me one sec, I need to reduce the size of this. Yeah. So we already know that C-section, so we already know that catecholamines and glucocorticoids are the two substances that are required to drive this process of increased ENaC expression and therefore resorption of the fluid. Now, when you do know that C-section means that the patient does not undergo labor, and in labor these substances are upregulated in the mother's and the baby's system. So if a patient has C-section, they won't undergo labor, these won't be increased, and therefore the child has an increased risk of developing transient tachypnea. All right, and then rapid vaginal delivery also, even though they're undergoing labor, it happens very quickly. And Now, you need to understand that gestational diabetes is in itself not a risk factor. You want to be thinking like gestational diabetes causes fetal macrosomia, and that increases the chances of the lady undergoing C-section, and it also increases the chances that there will be preterm labor and therefore prematurity. So that's how you need to connect gestational diabetes, fetal macrosomia, and prematurity as risk factors for this condition. All right. Now the presentation is pretty straightforward. It's just going to be mainly respiratory distress. You want to be looking for like tachypnea, retractions, grunting, hypoxemia, and just the usual stuff, right? And on imaging, it will show a fluid in the interlobar fissures. This is very, very classic of transient tachypnea, and lung hyperinflation because the fluid hasn't cleared out yet, so the distal lung could undergo hyperinflation. The important thing to know is that this self-resolves in 24 to 48 hours, right? So you just have to give supportive care and supplemental oxygen and just keep monitoring the vitals and just give supportive care, and the baby will recover in 24 to 48 hours. It presents almost immediately after birth because, I mean, that's just common sense. And then within 48 hours, it does resolve, right? So that's about TTN. This is pretty much all you need to know for the boards. I hope this was helpful and I hope you enjoyed it. Don't be confused, just be curious and think about the pathophysiology of any um, new disorders that you may come across, and you'll be able to understand it and crack the questions on the boards with relative ease. Thank you so much for listening. Have a wonderful rest of the day.